Multiple myeloma. Etiology and pathophysiology. The cause of multiple myeloma, MM, is unknown. Radiation may be a factor in some cases, although there is no association with therapeutic radiation. Exposure to industrial or agricultural toxins or viruses, e.g. human herpes virus 8, have all been considered, but proof is lacking. MM has been reported in familial clusters, suggesting a genetic element in some cases. Myeloma is characterized by the accumulation of clonal, malignant plasma cells in the bone marrow compartment, although the site of origin of the precursor cell is unknown. Recent advances in molecular biology suggest that the final oncogenic event occurs very late in B-cell differentiation. Chromosomal abnormalities have been identified, most commonly involving the immunoglobulin heavy chain switch region, on the long arm of chromosome 14. However, it is likely that additional events are required to develop the malignant disorder. The tumor cells within the bone marrow are supported by a non-malignant population of stromal cells that produce cytokines, e.g. interleukin-6, that enhance myeloma cell growth and prevent apoptosis. Epidemiology. MM accounts for about 10% of hematological malignancies. The annual incidence in the USA is 4 per 100,000, it is slightly lower in the UK. Black people are affected twice as commonly as white people, and males more than females. The median age at diagnosis is 65 years, with fewer than 3% of patients presenting when they are younger than 40 years. It has been suggested that the incidence is increased in patients with HIV infection. Clinical presentation. Common bone pain and pathological fractures. Anemia, bone marrow failure. Recurrent infections, due to immunoparesis. Hypercalcemia. Renal failure, multiple etiologies, hypercalcemia, direct effect of light chains, hyperuricemia and nonsteroidal drugs. Abnormal bleeding, due to platelet dysfunction. Rare. Hyperviscosity syndrome, ischemia, heart failure, and neurological problems. Amyloid disease, e.g. carpal tunnel syndrome. Investigations. There are a number of major and minor criteria required to make a diagnosis. In principle, this rests on demonstrating two or more of the following: a monoclonal protein in the serum, urine, or both. This is IgG in the majority of cases, but can be any class of immunoglobulin. Bence-Jones protein, BJP, in the urine consists of free light chains, either or lambda. Reduced levels of the normal immunoglobulins are supportive. Bone marrow showing increased plasma cells, more than 10%. Fig 20. Skeletal survey showing lytic lesions, Fig 21. Other findings include FBC and erythrocyte sedimentation rate, ESR, can reveal normochromic, normocytic anemia. The ESR is raised because the positive charge of protein neutralizes the negative charge of sialic acid on the erythrocyte membrane, and this reduces their natural tendency to repulse each other. Biochemistry can show raised calcium due to bony destruction, usually with a raised alkaline phosphatase. This may lead to dehydration and renal impairment. Staging, Samanduri. Staging relates to disease bulk, Table 13. Differential diagnosis of a serum paraprotein. Malignant. Waldenström's macroglobulinemia. Lymphoma. Chronic lymphocytic leukemia. Primary amyloidosis. Plasma cell leukemia. Benign or stable. Monoclonal gammopathy of uncertain significance. Cold hemagglutinin disease. AIDS. Treatment. Myeloma may present as an acute emergency. Acute renal failure, prompt treatment of volume depletion is critical, involve the nephrologists early. Hypercalcemia, fluids and bisphosphonates are critical. Spinal cord compression, a radiotherapy emergency. Hyperviscosity syndrome, consider plasmapheresis if there are hyperviscosity features. Specific treatment depends on disease stage, as well as other factors such as age and the presence of poor prognostic factors, see below. There is no known cure for myeloma, but in recent years the treatments for it have improved dramatically. Many patients may now achieve a stable remission, lasting a number of years, through a combination of chemotherapy and autologous stem cell transplantation. Most hematologists will participate in trials, which ensures standard treatment for patients and access to drugs that may be financially unavailable otherwise. Chemotherapy. Chemotherapy treatment, in combination with steroids, is the mainstay of treatment in newly diagnosed patients. More recently, many trials will include treatment with thalidomide, which has been shown to have significant anti-myeloma effects. These regimens can be given as pulsed therapy, i.e. repeated at regular time intervals, either orally or as intravenous infusions. The response rates are high, some patients enter complete remission, but most enter a plateau phase with a lower but steady monoclone. All patients will eventually relapse. More intensive regimens are used in younger and fitter patients, and these can be used to debulk disease prior to transplantation. Autologous stem cell transplantation. The safety of these procedures now means that they have become applicable to a larger number of patients. Many hematologists would consider patients up to the age of 60 as eligible for a transplant as part of their first-line treatment, i.e. debulk with chemotherapy first, but proceed directly to transplant thereafter. This obviously depends on the overall condition of the patient and his or her response to chemotherapy. Second autologous transplants may also be performed, often with good results. Allogeneic stem cell transplantation. This is only an option for a minority of patients, particularly those who are young, fit and have a human leukocyte antigen-matched sibling, or well-matched unrelated, donor. Response rates are high, but unfortunately relapse is common. Maintenance therapy. Interferon alpha has been used as maintenance therapy, and this can prolong remission following chemotherapy and transplantation, but it has not been shown to influence survival. More recently, thalidomide is being used as maintenance therapy and early results are encouraging. Toxicities of this drug include thromboembolic events and peripheral neuropathy. Warfarin may be prescribed with thalidomide to reduce thromboembolism. Plasmapheresis. Plasma viscosity may provide an indication for plasmapheresis, but clinical features are far more important. Evidence of critical ischemia, neurological syndrome, or coma may improve following this intervention. There is also some evidence that this may be helpful in patients who present with severe acute renal failure. Supportive care. Hypercalcemia should be managed with fluids and bisphosphonates initially. Bisphosphonates should be continued on a monthly basis, even with a normal calcium level, as there is a suggestion that they may reduce bony disease and modulate the disorder. Pain is common in myeloma and often requires opiate analgesia plus NSAIDs. Radiotherapy may be helpful in controlling pain due to localized bony lesions. Recurrent blood transfusions and antibiotics may be required as a result of both the disease and the treatment. Weekly erythropoietin injections may prevent anemia. In patients who have recurrent infections, prophylactic infusions of intravenous immunoglobulins should be considered. Psychological support. The patient will almost certainly need some help in coming to terms with the diagnosis. Try to involve family or friends, particularly when first explaining the situation. Societies exist for support and information, and the patient should be given access to these. Prognosis. Median survival with chemotherapy is about 3–5 years. Poor prognostic factors at diagnosis include higher stage, high beta-2 microglobulin, raised C-reactive protein, renal failure, urea more than 14 mol/L, certain chromosomal abnormalities, low albumin, older age. Recent studies suggest that a combination of beta-2 microglobulin and albumin are the most important factors.